Hello and welcome, and we're discussing the Women's Health Strategy 1 year on, and the hashtag for this discussion is Women's Health Strategy. This discussion has been made possible thanks to the kind support of Merck, the pharmaceuticals company, and the professional body, the British Fertility Society. I'm Sarah Norcross, the Director of PET, and I'll be chairing the discussion. In June 2021, PET submitted a detailed response to the government's call for evidence relating to the Women's Health Strategy, as did the British Fertility Society and many other bodies and interested individuals. When the Women's Health Strategy was published on the 20th of July in 2022, it was much later than had been anticipated. Indeed, there had been gossip in policy circles that the whole thing would never see the light of day. But it came out. And PET had just recently, in fact, in the June of 2022, published our own report, Fertility, Genomics and Embryo Research, Public Attitudes and Understanding. And one of the questions that we'd asked in that was around NHS-funded fertility treatment, and 2/3 of the public supported NHS-funded fertility treatment to people who are infertile. So we were very keen to see what the strategy would say. And I wrote about our views on the Women's Health Strategy at the time it was released. And it gives me absolutely no pleasure whatsoever to be proven right in our analysis and critique of that strategy to date. Few commentators remarked on the key thing missing from the strategy in one word: money. There was no commitment to provide the money, which is tiny in health budget terms, to fund equitable access to fertility treatment in accordance with the current or forthcoming NICE guideline, or indeed in relation to same-sex female couples. Some of the commitments we continued, such as they are in this strategy, left us thinking, but shouldn't you be doing this anyway? For example, updating the NHS website on fertility and improving signposting to the HFEA website. As for more concrete commitments in the strategy, such as removing non-medical eligibility criteria, what is their status? We asked, will it be mandatory for commissioners to remove such criteria from their policies? If so, when? How and by whom will this be enforced? The Women's Health Ambassador, Dame Leslie Regan, and a Deputy Director from NHS England were due to speak at this event, but both have withdrawn. Dame Leslie Regan said, "I'd like to thank the event organisers at PET for their kind invitation to speak at this event, as well as their ongoing work to support the Women's Health Strategy. I am unfortunately no longer able to attend or speak at the event. The Women's Health Strategy is committed to improving access for female same-sex couples by removing additional financial barriers. Integrated care boards, ICBs, are responsible for applying this locally. We recognise that there's been a delay in implementing local action. NHS England is developing advice to assist ICBs deliver this policy, and this work is ongoing. I would like to reassure PET and anyone attending the event that we remain determined to delivering this commitment, and ministers will update on progress in due course." The Deputy Director of Nursing from NHS England said, "Unfortunately, due to unforeseen pressing priorities, I am now unable to attend this event, but ask that you reassure attendees that our work to support the fertility-related aspect of the Women's Health Strategy continues." We at PET decided we'd press ahead with the event. As Dame Leslie herself said at our annual conference last year, we need to hold government's feet to the fire when it comes to fertility-related issues. And I think I'd go further than the Women's Health Ambassador and say that I would also include holding NHS England's feet to the fire too. PET's Power of 3 campaign aims to raise awareness of the importance of 3 full cycles of IVF being provided in England as it is in Scotland. This is a topic and an area that PET is very engaged in. So let's press on with tonight's expert panel. So we have Professor Geeta Nargund, Nickie Aiken MP, Isaac Barnswell, Laura Rose Thorogood, and Dr. Raj Mathur. Our first speaker this evening is Professor Geeta Nargund. Geeta is co-founder and medical advisor at Ginsburg Women's Health Board. She is lead consultant for reproductive medicine at St. George's University Hospitals, and she's the medical director of Create Fertility and ABC IVF.
What's the current state of play when it comes to gender health gap in the UK? And I have just listed a few things here just to give you a snapshot. And the situation is pretty depressing. The UK has the largest gender health gap in G20. It's the 12th largest globally. Less than 2.5% of publicly funded research is dedicated for reproductive health, when in fact 1 in 3 women suffer from reproductive health problems at some stage in their lives. It takes an average of 7.5 years to get the diagnosis of endometriosis. Around 60% of ovarian cancer cases are diagnosed too late in England. Women are 50% more likely to receive a wrong initial diagnosis when having a heart attack. When it comes to dementia, women receive worse medical treatment than men. After surgery, women are half as likely to receive painkillers than men. And women's pain is frequently labeled as emotional in their medical notes. So if we look at the current state of play, and what's going on with gender health gap, it is unacceptable and it is depressing. There are welcome proposals in the women's health strategy. Mandatory women's health training for all new doctors from 2024, really welcome proposal, particularly when you look at the curriculum for medical schools. 25 million funding to create new women's health hubs, one-stop shops in community settings. Very important proposal that, if it does happen, it should help to reduce the waiting lists and reduce the burden on secondary care. Removing non-clinical criteria to accessing fertility treatment. This removes additional barriers faced by female same-sex couples when accessing IVF treatment, and improving transparency to tackle the IVF postcode lottery. What we really want is the end of postcode lottery. What we need now is for the government to deliver on priority areas and turn these proposals into actions. As regards to rethinking of IVF funding, this is something I have published previously in a peer-reviewed paper. Now we are looking at, if we look at the data, national data, just under 4,000 fewer IVF cycles were funded through the NHS in 2021 compared to 2019. That could be the effect of COVID and long delays in the NHS. That could be one of the reasons. Only around 12% of CCGs, now ICBs, provide the NICE recommended 3 cycles of NHS-funded IVFs to couples in England with a defined cause of infertility. With birth rates falling and with an aging population that we have in our country, and with 1 in 7 couples suffering from fertility issues, this funding just isn't enough. In my view, introducing a national tariff would cap the amount providers can charge the NHS, limit that amount, and it will help increase the number of cycles funded within the existing budget. Bear in mind that the peer-reviewed scientific publications have shown that the lifetime economic value of an infant born in the UK is more than £700,000. This is a huge return on investment for our government. And based on these economic studies, and of course there are a number of other reasons, I believe IVF costs don't have to be borne by the DHSC alone. They could be spread across departments that would benefit from population growth and also upholding the equality and diversity agenda that we very much need in our progressive nation. And I believe the Treasury, the Department of Work and pensions and also women inequalities could collaborate and come together with DHSC to achieve this IVF funding we desperately need across our country, equal and fair access, and to end the postcode lottery. When it comes to disparities in maternal outcomes, it's very depressing. There's a shocking disparity in maternal health outcomes across ethnic minorities. Embrace report published in November 2022 showed that Black women were 3.7 times more likely to die than white women, and Asian women were nearly twice more likely to die than white women during pregnancy or up to 6 weeks after delivery. This is shocking statistic and really depressing. And Embrace also said that improvements in care may have made a difference to the outcome of 38% of women who died. 1 in 9 of women who died during or up to a year after pregnancy in the UK were at severe and multiple disadvantage. And women living in the most deprived areas of our country have the highest maternal mortality rates. So the Women and Equalities Commission published a report in April this year, and it has called on the government to set a definitive target to eliminate disparities in maternal deaths. The Maternity Disparities Task Force should, according to me, lead a collaborative strategy across all government departments. There are many government departments that should care about this, and with NHS leadership to tackle racial and ethnic disparities, address staff shortages, and provide additional investment for maternity care. That is the only way we can end these disparities. When it comes to menopause support, menopause has been in the news quite a lot in the last year or two, quite rightly so, because pre-pandemic research showed that women over the age of 50 were the fastest growing group in our workforce, with around 4.5 million aged 50 to 64 in employment. Findings from Fawcett Society and also Channel 4 suggest that 1 in 10 women have left their jobs due to their menopause symptoms. Health and Her estimated that menopause cost the UK economy 14 million working days per year in terms of time spent alleviating menopause symptoms. Shockingly, in 2019, Bupa found that almost 900,000 women in the UK had left their jobs because of menopausal symptoms. 1 in 3 women said they were unable to go to work because of their symptoms. And another report published in 2022 showed that over 1 million women could leave their workplace due to lack of support for menopause from their employers. And I'm hoping Nickie Aiken will address this in her talk. What has happened from the government or parliamentary side of it as regards to menopause support in the last year? Well, there was a debate about making HRT free, which I'm sure you have all seen. But what has been introduced is this HRT PPC, which is the prescription prepayment certificate, which was introduced in April this year, which is a one-off payment. I think it's £19.30 or so for both estrogen and progestogen. And it covers an unlimited number of HRT prescriptions over 12 months. It does not include all HRT prescriptions. However, it does include most HRT medicines. And Women and Equalities Committee, in fact, also published a report in January this year and made several recommendations. Those recommendations need to be followed up and reviewed in order to look at this menopause and HRT support from our government. So if we want to achieve the lasting change that is desperately needed for women's health in our country, I have listed a few things that I believe are quite important. I believe collaborative working is important. We need action and engagement with all stakeholders, including the Office for Health Improvement and Disparities, as well as government departments, the National Health Service, voluntary sector and private sector and local communities to achieve much needed community-based care and also education and prevention side of it. So we have got to bring all sectors together to raise awareness, educate, and prevent. We need an intersectional approach, which is vital to shift the dial for women from all sections of our society, including the LGBTQ community. We must remove barriers to entry. We must remove stigma regarding women's health issues, both at all places, so that women are able to talk about their problems and healthcare professionals can listen to those problems. We need to improve access to IVF treatment, introducing a national tariff, ending the postcode lottery. It can be achieved, many of this within the existing budget. We need to tackle ethnic and other inequalities in our country. We need to approach health challenges from an intersectional and cross-sectional standpoint to eliminate the health inequalities that exist, experienced by women from BAME communities, as well as those from lower socioeconomic backgrounds. Enhancing workplace policies, tackling the gender health gap at work could play an important role in closing the gender health gap, because women need to thrive at work, and that can only happen if women's health strategy is implemented, and it's implemented along with employers. And we need to pilot these schemes more broadly and in reducing gender inequalities across our society. And what's more, like everything in health, we need to invest in technology and innovation and upskilling for prediction, early diagnosis, and prevention of women's health conditions. And I believe if we address all that and implement women's health strategy, then women's health would certainly improve. Communities, countries, and ultimately the world are only as strong as the health of their women.
So next we have a pre-recorded contribution from Nickie Aiken, the Member of Parliament for the Cities of London and Westminster. And Nickie is the MP who is proposing the Fertility Treatment Employment Rights Bill in Parliament. And she's also launched the related Fertility Workplace Pledge.
I want to congratulate PET on doing an absolutely outstanding job on highlighting issues around fertility and assisted conception, and also for this outstanding conference today. Well done. And for all your support for my own campaign to secure employment rights and paid time off work for people undergoing fertility treatment under my Fertility Workplace Pledge campaign. I think it's really important that the government launched its women's health strategy last year, and that there is mention of fertility treatment there, but not enough in my considered opinion. So let's all work together to ensure that anybody undergoing infertility treatment does feel supported, can have a conversation with their employer without fear of their jobs, and together we can make it so much better for everybody.
So our next speaker is Isaac Barnswell. Isaac is Research and Policy Officer at Stonewall, and he is the leader of their IVF for All campaign.
I'm going to give a brief summary of the research that I've done on ICBs and the implementation of the Women's Health Strategy. A brief background of the most common treatment options that many female same-sex couples use. So in vitro fertilization or IVF, and intrauterine insemination, also referred to as artificial insemination. So most female same-sex couples tend to use IUI first, which is cheaper and also uses a main pathway of gaining eligibility for further IVF treatment on the NHS. In terms of costs, according to information from the HFVA and the NHS, costs range from £350 to £1,600 for each cycle of treatment. However, that doesn't include additional fees such as screening, medication, and donor sperm, which again, that will raise costs up to £2,000 to £3,500. So countless female same-sex couples who need IVF have to pay between £9,600 to £25,000. That's depending on the number of cycles required by regional integrated care boards or ICBs. Obviously, that clearly represents a significant financial barrier to many female same-sex couples. The Women's Health Strategy clearly promised to remove these additional financial barriers, including the requirement to privately fund artificial insemination. However, progress has been incredibly slow, and many LGBTQ+ couples still encounter many inequities, financial barriers, and fertility services. And we have also noted there's been a clear reticence from both the government and NHS England to actually take responsibility of this issue and to outline clear steps as well as a clear timeline on their implementation of the strategy's recommendations. So the majority of ICBs in England still require LGBTQ+ couples to pay privately for 6 or more cycles of IUI before they're eligible for IVF. So according to research which I did earlier this year, 93% of ICBs are still falling short of this target, and obviously forcing many female same-sex couples to pay thousands of pounds for private treatment. 19% of that figure do not even meet the requirements of the 2013 NICE guidelines, which offer a maximum of 6 cycles, and instead require up to 12 self-funded cycles of artificial insemination. So for some ICBs, they haven't even aligned with the 2013 guidelines. So this means that many couples have to pay up to 25,000 before accessing NHS-funded IVF, which is just insane. Only 5 out of the 42 ICBs have policies that are officially under review. This is from recent months, and this is in direct contradiction with Maria Caulfield's statement recently, saying that obviously the implementation would be going ahead this year, and only 5 out of the 42 are officially under review. And only 3 ICBs do not require female same-sex couples to actually pay for artificial insemination, which is just very shocking. So in terms of our key recommendations, we believe that all ICBs should provide equal access to NHS IVF treatment across England, and this should also be reflected in the next NICE guidelines in 2024. We also believe that the Secretary of Health and Social Care, Steve Barclay, should take responsibility and ensure the full implementation of the strategy's commitments and an end to the postcode lottery, as mentioned before, working diligently with both NHS England and all ICBs. And set out a clear timeline for the implementation of the Women's Health Strategy's commitments. So in terms of our current actions, firstly, we've been providing information and platforms to our supporters. So as an organisation, we have been engaging our supporters by providing a platform on our website where they're able to write letters to their MPs describing the issues in their own constituency, as well as this and our collective demands. In terms of engaging with Parliament, we also set up meetings with members of the health department. Most of the time it's chasing down. It's been very hard to actually get a meeting with them. Also sending many letters as well to the health secretary, but also relevant ministers and MPs on both sides of the aisle who may be interested in our aims. Also, we've been forming collaborative relationships with other organisations in this space, such as LGBT Mummies, headed by our next speaker, actually, Laura Rose. Ultimately, we also would like to get a parliamentary debate scheduled after the Parliament summer recess. So the issue of this delayed implementation rises up the priority list, as well as other actions where we'll elevate the voices of real-life couples who have faced such unnecessary barriers and the emotional toll that actually takes.
Our next speaker, Laura Rose Thorogood. Laura Rose is the founder of LGBT Mummies and Proud Foundations. She is a mother of 4 children via IUI and IVF treatment, and she's also the co-author of research into increasing use of IVF by same-sex female couples.
As an organisation, our sole purpose is to educate, support, advocate LGBT+ people worldwide on the path to motherhood or parenthood. And we provide a global community, support groups, events, education and training, and we passionately campaign for change for all LGBT+ families. And we fight for equity and equality for families through maternity, general healthcare, society and law to be equal to our heterosexual counterparts. So 77% of 18 to 35 LGBTQ+ people in the community want children or already have them. And that's based on the Family Equality Report, which is a huge and exponential growth in the past few decades. 33% increase on all fertility treatment for same-sex couples, specifically for IVF, and 17% for donor insemination, RUI, and that's from 2019 to 2021. But that also doesn't include single women and people. So that would also increase that too. The NHS-funded cycles have decreased by 16%, the HFEA reported in their 2023 report this year, from 2019 to 2021. So it's already not very encouraging that everything's declining, not just for us, but heterosexuals. However, as a community, we are pretty much on the back foot. So the Women's Health Strategy, a year on, just some headline numbers, which you've already heard from the others, including Isaac. Only 3 of 42 ICBs currently give equal access. That means no self-funding required. And what you may see is a lot of ICBs making a lot of noise, or in some cases doing it very quietly, saying that they do give equal and equitable access. What they mean is actually they give equal access after same-sex couples have to self-fund, where heterosexuals do not have to self-fund. It could be anything between 1 and 2 years before they get access to support and fertility if it's available in their postcode. However, we, of course, have to self-fund 6 to 12 rounds, depending on your ICB criteria, before they'll consider you, and they class that as equal access. We know that's not. It's very disparate and discriminatory. It's not mandated. So what the DHSC and the NHS and the government have decided to do with the Women's Health Strategy is put forward an ambition, a 10-year plan. It's evasive, it's vague, and it's a smokescreen to say that actually in that 10-year plan, we will aim to and push our ICBs in a non-mandated way and at a localised level to try to work towards equality. It's not good enough. Not mandating it, making it a guideline rather than a policy, means that ICBs can say, actually, our budget doesn't allow for us to be equitable and provide equal access to LGBT people. And all that actually our community that are actually having access is same-sex couples. And I'll talk a bit more about that there are a huge portion of our community that are left out that we want to campaign and fight for too. People are being also stopped from other pathways, and this isn't talked about as much in regards to the Women's Health Strategy, but people have come to us and shared their experience that they're going down the home insemination route because this is the only option left in which them or their partner or partners can birth a child of their own genetically. And so are going down alternative routes. And when they go down alternative routes, asking the NHS for support in regards to medication, and they are being told and declined, no, we will not give you access. They cannot get it through a private clinic unless they're having treatment. So that medication, they're even willing to pay for themselves, and they're being told no. So they're having alternative routes blocked alongside being discriminated against and not giving access on the NHS for fertility funding. It also, as I mentioned, excludes others in the LGBTQ plus community and other family makeups. Single women and people, and I use women and people because I'm talking about trans and non-binary people and genderqueer people that get left out. Trans men, gay dads and intersex people aren't included in the Women's Health Strategy. And again, additive language would have been really important and wanted at the beginning, and it's something we addressed with the DHSC. What are the implications of lack of funding access? We can talk all about the numbers and how difficult it is and how disparate the access is. But when it comes down to it, we need to talk about the physical, psychological and financial impacts that not having access has on our community. People are getting into debt. People are buying getting credit cards, getting loans out. They're also getting in debt with finance options, which means that they can't actually then afford to do it, but then they're having to pay interest back also, which adds that additional barrier and additional layer of stress. People are talking to us and saying they're lending money off family, which they know that they're going to have to take a long time to pay back if they can at all. And people are actually going online and buying the medication that they are being declined from the NHS for home insemination so that they can attempt to get pregnant, which again is putting themselves at physical risk. There's dangerous online and in-person encounters whereby people are going online to find donors to do home insemination. And whilst we fully support home insemination and those that choose that route, some people are being pushed down that route as an alternative route. It's not their chosen route and are doing so without understanding the physical, psychological and legal implications that can occur for them, any known donor and any future child that they're going to bear. They're then also putting themselves at risk with STDs, potential baby genetic conditions that they're not aware of because they've not gone through a private clinical route or a funded route because it's not available, and potential miscarriage or baby loss, which can occur if these issues arise. There's often alternative mental health issues that come out of having to try to conceive in a different way or not having access, and it's impacting not only the woman or birthing person, but also their partner, partners or co-parents. It also leads to parental legal issues whereby people not being married or civil partnered won't have access to parental rights. They'll have to go down second parent adoption, or in some cases are coming to us in really difficult situations whereby they're having to go back to court to discuss intent, parental responsibility, donors changing their mind and putting themselves, the donors and their children in really difficult legal situations, physical and psychologically damaging. Further discrimination is adding to those additional areas where people are further being discriminated against, and the cost to the government of those implications, what does that look like? And for us, the question is, what is the true cost of these additional implications in comparison to actually providing funded access to our community? The cost of that must be quite a big one. We are a community impacted, and we have so many people giving us evidence, which we are collating in collaboration with Stonewall and our fight and campaign for people in our community to get funded access. People are telling us that if we don't get funding, our dreams of having a family the way we want to are gone. They haven't got that opportunity, and we'll have to look at alternative routes if they can. We don't just have 30k to start a family, so we are having to consider routes that put us at risk. We had someone come to us saying, I have a trans wife, but they don't provide same-sex couples in our ICB with treatment, even though she'd be providing her gametes. They won't be able to have access. My ICB doesn't provide access to medication. I have severe PCOS and asked my GP for medication to support home insemination. Guidelines say that they can, but he refused. So they are stopping us from trying to create our family at home as well. Again, blocking those alternative routes, which is impeding people's journeys and pathways. We've also had people saying we've suffered 2 losses and had 4 failed cycles with home insemination, but we aren't eligible for funding because it wasn't done by a private clinic. So again, it's not just not having access to funding, it's the implications, it's the alternative pathways that are being blocked, and people are being impacted in a great way, not just financially, physically and psychologically. Just to sum it up, this is the queer experience in a gendered system. It isn't built for people like us. It's not equitable, it's not equal, and we are consistently having to fight back on this. And 1 year on, we are still on the back foot. So what do we want? I've put together a great list of the 3 things that we want, but as a whole, I've been quite greedy. And as an organisation, we want more. We want equal and equitable access, equal to our heterosexual counterparts. We all should have an equal playing field whereby we have the access that we all deserve. We want a national mandated funding criteria for all ICBs. We don't want it at a localised level whereby they can palm us off it, so to speak, and say that actually they don't have the budget or funding, they can't allocate that because that's all they have. We want it nationally and it mandated. We want the ability for people to have informed choice and make informed consent on the choices they make. The ability to choose between treatments. Not everyone needs IVF. Some people are of a situation whereby their body or their partner's bodies are able to carry a birth without going down the IVF more medicalised route. Some people are victims of rape, of trauma, and decide they don't want to go down an invasive route. It's too much for them. And there are others that don't want to go down a medicated route. It's not right for them. IUI is much simpler, less costly to the system, less invasive. People should have access to make that choice rather than jumping to a much more costly and physical and invasive route. We want personalised fertility care, again, based on need. What does that person or those people in front of you need? We want education for staff. There's a huge gap, and we've been consistently talking and making recommendations to the government that all midwifery staff, all healthcare professionals should have a basic level understanding of fertility care, in which case most of them don't at present, and it's not mandated. Access to funded medication and tests for home insemination. This is a given, it's a guideline and it is accessible. So why are people being told that they cannot have access and being denied the right? Co-produced funding provisions with the community. These are conversations we should be having at a strategic level. Organisations like us, Stonewall, but also people out there that are having the lived experience of being physically and psychologically, emotionally impacted. We all need to come together and have sensible and constructive conversations about what is needed and what our community should have access to. The ability to create our family safely by our chosen routes. It's quite simple. If you are medically able to have a child by your first chosen route, we should all be able to have that equal access. And that ability to purchase sperm and free for future siblings. Cycles, what's happening at the moment is that those that are getting access in those ICBs are being told they have to order 1 vial of sperm at a time from someone that's had 11 years of fertility treatment and multiple failed cycles and secondary infertility. I can assure many people on the call that don't know, if you have one vial and you only get 1 embryo, that's it, you've got to try again. And we are hearing from a lot of people that are saying that actually their one vial has run out. They've got to wait up to 9 months to get access through the NHS, through the only sperm banks that they use, to then start again, choose a donor, and it is delaying their journey and impacting their fertility. Some people haven't got that time to wait. And in general, as a whole, many people have not got 10 years to wait for them to be able to start their family. So what's next? We've got ongoing campaigning with LGBT Mummies and Stonewall, and getting people with lived experience involved to share their experiences. We are collating that evidence. Again, parliamentary debate, which Isaac mentioned, is something that we are really passionate about, getting in front of the government and having a conversation, a sensible conversation with everyone having a seat at the table to talk about those implications that I mentioned and why we need equal access. And for us as an organisation, it isn't about those that just identify as same-sex couples or that are same-sex couples. It's a whole community. There are many, as I mentioned multiple times, that are left out of this. And that the strategy isn't just a women's strategy, it's a women and people strategy. It's a strategy that should include our whole community.
So finally, to conclude the presentations, we have Dr. Raj Mathur. He's a consultant gynaecologist and lead for reproductive medicine at St Mary's Hospital and Manchester Fertility.
So the Women's Health Strategy was described by itself as a 10-year strategy with a range of commitments to improve the health of women everywhere. And it is true that this was developed following a long and comprehensive consultative process, extensive consultation. 400 organizations, more than 100,000 individuals gave their views. The British Fertility Society submitted detailed input. And it is a very comprehensive document. It covers a very large range of aspects of women's health. And importantly, when the strategy was launched, we also got our first Women's Health Ambassador. And I think that is actually not to be underestimated as a game changer, really. And that is a game changer for the future as we move forward. Now, one of the 7 priority areas identified in this strategy were fertility, pregnancy loss, and postnatal support. That pretty much encompasses most of obstetrics and gynecology. Perhaps menopause is not mentioned in there, but practically everything else is. I'll talk specifically about fertility, and there were a number of commitments that are relevant to fertility in the strategy, and I've listed them on the screen here. So an important commitment was that the current geographical variation in access to NHS-funded fertility services would be reduced or would be tackled. This is the infamous postcode lottery, and it's laudable that the strategy acknowledges this and wants to tackle it. It wants to commission services in a clinically justifiable way, which is, I think, again, a good aim. There is talk about publishing data nationally on provision and availability of IVF treatment. And as other speakers have already alluded, it promises to remove non-clinical access to criteria, non-clinical access criteria to fertility treatment, such as, do both partners need to be childless, or is it okay if one partner has a child and one doesn't, etc. And finally, there were specific aims set out in relation to female same-sex couples to ensure that there is no requirement for self-funding and that the NHS treatment pathway for female same-sex couples can start with intrauterine insemination prior to IVF, if indeed IVF is necessary. There were further references to fertility in Parliament. In Hansard, we find that Maria Caulfield, Parliamentary Under Secretary of State, listed improving and standardizing access to IVF for same-sex couples as one of the 8 priorities for this year, that is 2023. So what have we seen? And this is my take on it as a clinician I'm not a policy wonk, leave alone a politician. But this is my take on it, looking at it as a clinician and being conscious of what colleagues in the country tell us. So I think in terms of geographical variation, I think it hasn't been all bad news. There has been some bad news, but there's been some good news as well, and I'll give you some examples of that. But it is fair to say that overall, IVF provision in England is still a postcode lottery. With regard to clinically justifiable commissioning criteria, there's been no change. As far as I'm aware, social criteria are in force across the patch and are different from one region to another. There is no national data published on availability of IVF, so there's been no progress there. And unfortunately, there has been no improvement, I think, in providing information about fertility. Now, the society that I chair, which is the British Fertility Society, is independent of the strategy, working with authorities to include material that we've developed about fertility education into the national curriculum. And we are hopeful that process is in its final stages. We are hopeful that that will be accepted for the national curriculum, but that actually isn't anything to do with the strategy per se. And finally, I think in terms of specifically access for same-sex couples, I don't see any real change across the board. But I don't want to be all doom and gloom, and it should be recognized that there has been some progress. And remarkably, this is in London, where two big integrated commissioning boards have improved their IVF commissioning criteria, their fertility treatment, generally fertility treatment commissioning criteria, quite significantly. And these are not insignificant. They cover population in total of 3.6 million. They've achieved uniform criteria across the ICBs, which were multiple different CCGs in previous parlance. They have watered down the social criteria as well. For instance, they say for couples that if one of the people in the relationship does not have a living child, then the couple are eligible. And for single person, they say that there should be no living child. They do fund donor gametes. And very importantly, for me as a simple clinician, when I read the London ICB criteria, they're actually really well written. I think the Plain English Award ought to commend them, because they're unlike any output I've seen from NHS when it comes to funding and criteria in the past. They're actually easy to understand. And hopefully that means that they're easy to implement fairly and openly. But in other areas, I have to say, there has been no progress. And I'm slightly ashamed to share this with you. This is a slide of a spreadsheet that we use in my department in Manchester, in the NHS service in Manchester. We deal with 23 different CCGs, and they all have subtly different criteria for accessing fertility treatment. As you can see, a number of these CCGs are now part of an ICB. So really, we've reduced down from 22 CCGs to 3 ICBs, which is progress. But you can see within the ICB itself, one ICB, some are still funding 1 cycle, some are funding 2, one is even funding 3 cycles. And so there's variation still within the ICB, which is unreasonable, to say the least. The other thing I would draw your attention to is that they've reduced from previously, these 3 CCG, as you can see here, were previously on 3 cycles, but they've followed what has been a rush to the lowest common denominator in the last few years, and they've all reduced from 3 down to 1. So there is unnecessary complexity, there is unjustifiable complexity, I think, in parts, certainly the part of the area in the northwest of England where I work, which covers 22 CCGs as used to be and 3 integrated care boards. So what would we like to see as NHS clinicians? Well, we would like to see evidence-based NICE guidelines implemented. And we don't think this is impossible. Scotland has managed to do it. Scotland is an example of very good funding criteria, which have been achieved within the health budget envelope that was decided for the nation. It has been achieved in the London ICBs, as we have seen. We would very much like documents that the public and patients in public can understand, and doctors can understand, because so much of my time is spent trying to decipher what they actually mean when they say a certain form of words. And this can lead to so much essentially incomprehension, not even miscomprehension, but incomprehension and misunderstandings between patients and doctors and funders. And I think we have to remove non-clinical social criteria. And I think if one partner has a child, to not provide that couple fertility treatment is really cruel. And it penalizes the childless partner for no fault of theirs, something that they've not had control over. That is contrary to every principle of natural justice. Of course, when it comes to same-sex couples, the strategy essentially needs to implement what it actually promises. I can't agree more with what Laura Rose just said. It's accepted in the strategy that the situation isn't right. It just needs to be done. My final point would be that I've talked about fertility, of course, but we do need to remember that fertility is one part of the wider picture of women's health. And actually, not just women's health, men's health. Men are often ignored when it comes to fertility, and I think too close an identification between fertility treatment and women's health is probably not a good idea. It's relevant for male health. Trans and non-binary people have fertility needs. So we do need to be able to address all of them and use inclusive language as much as we can without offending people. And there are examples across the system where fertility treatment is hampered because of other problems, such as when we have a backlog in the NHS of surgical cases, gynecological surgery is getting a raw deal compared to other surgical specialties. And improving that would speed access into fertility treatment, for instance. That is just one example from everyday life as a clinician in the NHS.
One point which you made there, and I think really needs to be emphasized and fed back, and anybody who's on the call who's listening who could do something about this would be greatly appreciated, is the lack of clarity in those policies. They need to be clear and easy to understand by the multiple stakeholders that access them, patients, doctors like yourself. I mean, we had a medical student reading them for us, our marketing manager Amanda. She was looking into them, I was looking into them to try and double check things. It's extremely confusing. You don't really talk about apples or oranges and bananas, and then whether they're throwing a cabbage and a radish in there to try and sort of unpick as to who is entitled to what and in what, it just seems incredibly complicated. And as you said, that most recent policy is a lot clearer. And I know that NHS England won't tell ICBs or whatever we're calling them in another 5 years what to do, but you'd think it wouldn't be, there could be some sort of template or guidance for these groups to use, because it would save them time. It would create a huge amount of efficiency if they didn't have to draft all the standard bits again. And I think I was wondering whether Isaac and Laura Rose, you've also obviously been looking at these policies in great detail, whether you've found it or whether it's just me and Raj who can't understand them.
I think they're purposely evasive to the point that people are coming to us and said, we've read them 5 or 6 times and they're telling us they're providing equal access, but what does it mean? And it's just written in such a way, and they're hidden on the ICB's website in such a way that no one can find them. So when we are going to people, and obviously Isaac's document that we've been looking at that they did work, it's just brilliant, because then it just gives you, this is exactly what the access is, but it's purposely evasive so that people go round in circles. And in many cases, most people's GPs have no understanding of how the funding provision works. So therefore they're going to their GPs, it's causing delay. They're saying, actually, we don't know, we don't have access. No, you don't, but they're not always given the full detail on what the criteria looks like. And again, there's a huge amount of discriminatory criteria in regards to BMI, but you get fobbed off with it's NICE guidelines. So anyone over the specific BMI set by NICE, you can't have access. Whereby in heterosexual relationships, you wouldn't say to someone you can't naturally conceive and have a child because you are larger bodied and you have a higher BMI. But yet we tell people in IVF, you're more at risk of miscarriage or potential pregnancy and birthing issues. Of course, that's truth, that's medically there in research, but we're stopping people from having access to start their family because of these additional barriers. So if you're LGBTQ+, you're Black, you're non-binary, you know, you're having no access to funding, you can't go through home insemination. You add all of those barriers together and you access to, you know, financial support or family support. There's so many barriers as a community that we have to overcome and face. But if you tick the intersectionality of ticking more than one box, and your outcomes are so low, you're at risk of such poor outcomes. And they do it because they know that people are going to get confused. A service user cannot understand the language that is put in most of these documents. So people are coming to Stonewall, people are coming to us to say, oh, where do we stand? And is this something that's going to change? We were all celebrating last year that the women's health strategy was coming in, and it was only after taking stock and sitting down and reading it over and over again and meeting with the DHSC and saying, actually, where do we sit with this? That it is an ambition, it is a 10-year plan. Oh, you know, NICE are going to review the guidelines in 2024. Does that mean that funding is off the table for everyone, or it's going to be reduced? You know, there's a sensible conversation to be had. We know that the money's got to come from somewhere, but you either give everyone access or you give no one access. That's an equal playing field. But people just don't know what they're entitled to. The GPs don't know what they're entitled to. There's no communication. GPs, ICBs, service users. It's just very evasive.
Yeah, and that ties in with some research for the Power of Three campaign that PET did this year, where we asked GPs about their policies, what the NICE guideline is, the current one, which we've had for nearly 20 years, and the level of knowledge was absolutely shocking. So we looked at 40 of the 42 ICBs because 2 we could not find their policies available online. And out of those, only 4 are offering 3 NHS funded cycles across their entire area. And that's to heterosexual couples. Of these 4 ICBs, only 3 of them are offering full cycles of IVF as defined and recommended by the NICE guideline. And furthermore, the recent move that we've been talking about from clinical commissioning groups to ICBs, combined with the fact that policies haven't been harmonised, means that in some places, like in Greater Manchester where Raj works, there is now a postcode lottery treatment within a single ICB. So we've got a sort of postcode lottery within a postcode lottery. It's mind-boggling confusing. It must be very confusing for the consultants as well to work out who's getting what and who they've got in front of them and what they're telling them. How much impact do you think the NHS staffing crisis, which disproportionately affects GPs and gynecology, will impact on the ability of the government to deliver the women's health strategy? What do you think can be done to improve retention and recruitment in these specialities?
Well, it definitely affects the current crisis when it comes to waiting lists. We see that already, even outpatient appointment delays, as well as Raj, I'm sure he will see that, he sees that as well. Long waiting times for surgery. So that is been happening. I mean, we had that during COVID. Quite clearly now, with this staffing crisis, it's going to continue. It's actually quite sad that it's going to affect. And of course, the strikes have also affected the waiting times, the waiting list for surgery. So it will continue. I haven't quite read the NHS workforce plan that has been published, but I have to say, it's a long shot. It's going to take time. Retention, I mean, I don't want to go into it. It's like the striking doctors are already saying what is needed to retain them. But the morale amongst doctors is quite low in the NHS. And it really needs to be addressed on all fronts to keep doctors in the National Health Service.
The NHS workforce plan is a little bit too high level. I think it has some good aspirations. People are very skeptical about the solutions proposed. But one thing it does get right is that it's not just doctors; it's also nurses and counsellors, and we are short of people. We are definitely short of people. What is good, I think, is that within obstetrics and gynecology, we do get a fair chunk of really clever people and motivated people who want to work in fertility. And that I think is a good sign. But there's a shortage overall, and that shortage is partly because it's difficult to train in obstetrics and gynae, particularly if you're a woman, and then also because retention is not what it should be. Morale is poor across the board.
In her forward, Amanda Pritchard, who's the NHS chief exec, describes the plan as a once-in-a-generation opportunity to put staffing on a sustainable footing and improve patient care. That while the plan contains references to maternity, midwifery, obstetrics, gynecology and reproductive health, it contains no mention of fertility, IVF or assisted conception more generally. And the only reference to the women's health strategy in the plan concerns helping victims of violence and abuse. The next question is, do you think that within the DSHC, so that's Department of Health and Social Care, and NHS England, there is enough resource, both funding and staff, going into delivering the women's health strategy commitments?
No, I don't think they've got enough staff to deal with most areas of the system anyway. The fact that most ICBs are being asked to cut their workforce or cut costs by 20% this year and another 10% further next year, the conversations that we're hearing is that a lot of staff are being either made redundant or moved into different areas or roles, or costs are being shaved in different areas, and therefore the care that's being given is not where it needs to be. This is where the staff shortages have that impact, whereby the poor outcomes happen, and those from those minority groups are going to be further impacted. The Black and brown women and people that are having poor outcomes, we're trying in so many areas, with the Embrace report, to reduce those poor outcomes, but at the same time, if you haven't got the staff to help support those improvements, you're not going to see those improvements. And again, with the women's health strategy, it does feel like a delay to say that we will make these changes within 10 years. Some people haven't got 10 years to wait. They can't put their fertility and their dreams on hold. And in another case, you hear a lot of people saying, oh, well, fertility, having children isn't something that everyone should have the right to. No, we believe that you should.
Look, as regards to staffing, there is a crisis, and also there's a skill-based problem as well. Okay, but as regards to resources, there is a problem, but there are ways of working within the existing budget. There is enough resource in our National Health Service. There's a lot of wastage happening, and the resources can be reallocated. For example, one-stop service, community-based care. The resources can be reallocated from other services to make that happen. So in some ways, there are some areas where you need new money, extra resources, and there are some where it could be achieved within the existing budget by allocating resources as it is needed when we change these strategies. So I think that thing is, to me, a low-hanging fruit that could be achieved because it doesn't require new money. But that, I think it needs attention to make that happen. So I would think that there are plenty of resources in the NHS. We need to stop wastage. We need to reallocate resources to make these progressive policies happen, one-stop services happen. And when it comes to equal and fair access, that's the founding principle of our National Health Service. Why are we even talking about that? Should be happening anyway across our country.
There seem to be a lot of different elements to the women's health strategy. Realistically, where do you think fertility sits in the priority list?
Fertility, as I said, it should be a very important priority for the government, because it's just not about health. It's about creating families. It's about increasing population. It's about creating future pension payers. It's not just, there are multiple advantages, economic advantages for our nation's prosperity alongside creating families. And on top of that, Laura and Isaac are saying about, creating diversity, creating a progressive nation, inclusiveness, diversity, equality, all of these fundamental principles of our society. There are multiple stakeholders. It's not just treating any health condition. And so it has got to be priority. It's got to be in the top two. Maybe to me, it has to be the top priority, but it isn't seen that way, which is why I believe fertility needs to be taken out of just the DHSC alone and other departments should come in to fund fertility.
It was interesting that one of our recent meetings where we had Dame Claire Gerarda, who's president of the Royal College of GPs, speaking, and she's a woman who's on every committee going. And I don't mean that in a disparaging way to her at all, but because of her status. And she just said, all the committees that I'm on, none of them talk about fertility. There's no conversation about that at all. She was getting quite frustrated, actually.
I don't think fertility is seen as a priority. Part of me finds it distasteful to have to fight other very deserving areas of women's health and for priority status. But what we need is for fertility to be treated fairly and for fertility to be treated in proportion to the importance it has. You create not only mothers and fathers, you create uncles and aunts and grandparents and what have you. It's really quite a massive social good. It helps people achieve way beyond just their health. It's a life aim. It is, as Geeta so nicely pointed out, it more than pays for itself in terms of the investment in the nation's future. So I think it does need to be elevated in terms of priority. I don't think that has been a complete failure, though. I'm old enough, I guess, to know the days when people going to the GP with fertility problems were essentially, in many cases, fobbed off. Told to go away, come back in a year or 2 years, or get a dog or something like that. Those, I think those attitudes have changed, and I think things can change. The fact that the media are interested in fertility, the fact that more and more people are happy to talk openly about their experiences, both of successful and unsuccessful fertility treatment, actually makes it a little bit more visible in the public eye. So I am hopeful, but it is nowhere near the priority it should be for its importance.
How much of a game changer can a women's health ambassador be if they're going to shift the blame for the postcode lottery for fertility treatment onto ICBs?
I take the long view. I think it's a powerful message to the health system that there is. It may not make a difference to the man and woman in the street, but it does make a difference to the bureaucrats, to the commissioners, to people sitting in integrated care boards. And I actually think that a women's health commissioner doesn't have to attend every meeting of every ICB where fertility is being discussed. But the fact that that person exists, that person makes a stand in favor of fertility or recognize the importance of fertility, can be picked up by people in each region who sit on these or go to attend these to raise the profile of fertility. So I look at this as something that should pay off over years. It hasn't yet, I have to say.
The use of IVF with same-sex couples is just wrong. At first, I thought they were opposed to same-sex couple having a family, but that isn't the case with this question. They're saying there are no fertility problems per se in 99% of the cases, apart from the age of the female. Often, and there's a sort of another sort of a couple of related comments about this, about IVF being overused and most people won't use it, and then a question about why Stonewall chose IVF for all, perhaps as the campaign name, rather than more access to maybe fresh as well as frozen sperm and cheaper IUI first. It can't be right to encourage IVF that isn't needed, as it has can have harms on women. It's not a completely benign treatment.
There should be that ability to make a choice and choose between IUI and IVF, and I think that should be available for heterosexuals as well. The jump to IVF is not only more costly for the system, it's also more invasive. There's more medication involved, there's more risk of multiples, which we know put all women and birthing people at further risk of poor outcomes and babies. But when it comes down to it, I think the person mentioned 99%. That's not entirely true, because there are many that we're seeing in the LGBTQIA plus community that come forward that actually, because as a community, we exponentially start our families much later. When we meet, whether you're a single woman or person by choice, whether you're a couple, whether you're co-parenting or you're a poly family, whatever your family makeup is, we do it later than heterosexuals. So when we get to that point, in many cases, many people come forward and get tested to find that they do have PCOS underlying, they do have endometriosis, they do have underlying infertility, secondary infertility. I myself have suffered from secondary infertility. And when they get to that point, that's when they're like, oh, is it too late, or could it be too late? Can I preserve my fertility?
The main purpose of the IVF for All campaign is about making all pathways to it, including IUI, more equal and equitable. So although obviously many couples do not need to go beyond IUI, many couples still, there actually has been an increase in female same-sex couples using IVF due to lower success rates. On average, it's about 20% success rate in comparison to about 50-60% for IVF. So at the same time, through our campaign, we've also been highlighting the issues of artificial insemination and the costs of that. As I said before in the presentation, most ICBs require up to 6 to 12 cycles, which is obviously a huge financial barrier. On top of that, there's a postcode lottery, as mentioned by Sarah. So, for example, like an LGBTQ plus couple living in Surrey Heath who are served by the Surrey Heartlands ICB, they do not have to self-fund for IUI, artificial insemination. However, a couple who lives in the same constituency but are served by Frimley ICB, where the CCG policies have not been updated, so they still apply, and they would have to self-fund 12 cycles of artificial insemination, which will be meaning paying up to 25,000. So we've been highlighting these issues as well. IVF for All is essentially just, as I said before, just making sure that everything that goes along with it, just more equal and equitable across the board.
What Isaac is saying as well with that campaign was that the NHS prolifically, when they do give you funding provision access, it is for IVF, it isn't for IUI. In most ICBs, you don't get any access via IUI. You have to self-fund for IUI, but then to get access to IVF, I don't know of many ICBs that even offer IUI at all, because they give you the excuse that there's not a high success rate, it can lead to further trauma, which of course it can, but IVF is more successful. But again, not giving you that space to make an informed choice and decision based on your own personalised need. So IVF for All, in many cases, is because that's what they're offering and that's all we can have. So unless that choice is changed, it would then be fertility for all.
It is crucial to respect people's ability to make informed choices. I appreciate everybody has a view on, on this quite often, but really it is down to the individual or the couple taking into account the information given to them by a trusted clinician. We shouldn't be second guessing these things. Laura Rose is absolutely right. A significant proportion of people, heterosexual or in same-sex relationships, will have underlying fertility problems. There may be issues with waiting, with availability of donor sperm, for instance. You want to use it in the most efficient way. It's not accurate, and it's certainly not helpful to say that they mustn't have IVF and they should just keep doing IUI till whatever length of time. And I also sympathize with Isaac for having a campaign that said IVF for all. You've got to have a snappy title for a campaign. And, it's not. There's a restaurant down the corner and it's called Coriander. But trust me, it serves more than coriander, but it doesn't list its entire menu in its name.
Could Raj or Geeta explain how a national tariff might be set?
We actually had a group. Raj, you remember, they set up by NHS England that we discussed extensively. Sarah, you were at it as well, I think, and about how do we go about it, standardize the cycle, and what should we include, what should we exclude. There was a lot of work put in, and we actually don't know what happened to that. I have no idea. I don't know, Raj, if you do. But yes, it could be achieved, just standardizing the cycle, and no doubt the price would go down quite a lot compared to what some providers are charging at the moment. And I don't know a couple of years ago, I wrote a piece in The Guardian about capping IVF price, how it can double or triple cycles. It's because at that time when we looked at it, I don't know, with the Croydon CCG, there was some funding, some ridiculous high price, like something like over 11,000, but nearly 12,000 pounds being charged, not anymore, by the way, for one cycle. So for exactly the same treatment, different NHS providers are charging different prices, and that cannot be right. Okay, particularly when there's high price, you've got to bring that down so that you can fund more cycles within the existing budget. There is some background work done already. I think what can be done is to continue that and come up with that. And I think we actually nearly concluded that. So it's there, and we really need to do that, because if the price comes down, I won't put a number on it, we will be doubling or even trebling the number of cycles within the existing project. It's a no-brainer. It needs to be done.
One of the problems was that I think a tariff is very prescriptive, whereas they were able to reach a benchmark figure, which is not prescriptive but more recommendation like. And I think even that would be a good start. The problem is knowing what to include in a price, isn't it? Different NHS clinics and private clinics do things differently. But I think a benchmark price is definitely achievable, and it should be something that we strive for. That could be one of the things that the commissioners look at.
We did reach an agreement on a benchmark price, but nothing really much was ever done with that. One of the drivers for that whole piece of work kicking off was some research that PET had done when we FOI'd all, and I think they were still CCGs then, as to how much they thought they were paying for a cycle of IVF. And it showed such huge variation in price that they were paying. And again, we didn't know, because I don't know whether they knew whether they were comparing apples with oranges here, but it showed that there was something wrong with the system. We've not repeated that piece of work. Perhaps that's something that PET will look at doing, or perhaps that could be done as part of the women's health strategy in taking this forward and removing it from the third sector to have to try and finance. How are ICBs justifying the limitation on vials of sperm? Is it cost or barriers put in place by a sperm bank? How is that happening? This person wants to know.
In many cases, ICBs are stating that the reason behind is cost. It's also down to the pandemic, because there is a global shortage of sperm donors, specifically certain demographics of those from ethnic communities. There is a real lack of Black and brown sperm donors available globally. And of course, there are people from those communities that have a desire to have children that look like them or their partners, and are therefore waiting an even longer time to find the right donor. And in many cases, a lot of ICBs only give availability through specific sperm banks, being ones in the UK. And in many cases in the UK, you only have access to 6'2", blonde hair, blue eyes, English. And that's all the information you get. There's no recordings, there's no genetic history, there's no immediate or extended family details. Whereas if you go to the EU, or you go like US or globally, if you go to a sperm bank for sperm, you get the ins and outs of the sperm donor's history, medical details, and his or their families as well. And in many cases, those that have to go down the route of having egg or sperm donation want to know that detail. They want photos for their children, and especially with the change with donor conceived children and people coming to the age, people want to be able to pass that down to their children. So having to go through NHS funded treatment is wonderful, but then again, there's an additional barrier, because you're not getting the information that you want to be able to box up in a memory box, or give, or discuss, or pass on to your donor conceived children as well. And again, it does in many cases come down to cost. If they can pay for one sperm vial as opposed to 3, because you hope to in the future have future children and siblings, they'll pay for 1. They're not going to pay for 2. And then what happens after you've had that pregnancy? You don't get funding. Who pays for the sperm to be frozen? How does that cost get attributed to that woman or person or that couple? There's so many different barriers that aren't thought out. These things, in many cases in reviews we've done with ICBs, are never discussed.
When the ICBs make these decisions, they rarely have an IVF doctor on their panel, let me tell you that for a start. They usually have one external advisor, and they might talk to 1 or 2 clinicians, but in general, they exclude people from IVF clinics, even NHS IVF clinics, when they make these funding decisions. So the Greater Manchester funding decisions, for instance, we had no input into. We only found out afterwards what the decisions were. I want to see my patients have babies, fulfill their life dreams. And actually that applies to my NHS patients, as well as the patients I see once a week in the private sector.
They don't have this problem in Scotland. They have much better access to fertility treatment for heterosexual couples and for same-sex couples as well.
It's done in Scotland, it's been done in Belgium, it's been done in many countries, and they used that years ago to come up with a price and to implement that. And there's a lot more funding that's happening. And so I think we should just get on with it, to be honest.